Hi doctors, how are you? This is Mohammed Musa from AFK Study Plan. This week we started our course for doctor aiming for August exam. In our course we believe studying and solving questions should come hand in hand from week 1. I'm not going to wait till like few months before exam and then I'm going to give you some question. Every Sunday in the morning we give what we call live quiz. In this live quiz, doctors doing between 20 to 30 questions and we do group discussion to discuss the concept. Because I believe knowledge is the key for you to pass AFK. It isn't about the information, it isn't about the question, it is about the concept of the questions, which most commonly high yield topic that you need to be familiar with. So any question you see in your exam, hopefully you can navigate through it and answer it. And for the next few weeks, I will try my best Sunday at night to post video like this. I'm going to pick only 5 questions, not from the question we have in full course. It's totally a different question, but aiming for the concept that I would love everyone preparing for the exam, getting my course, getting any course, doing self-study to be ready for this concept and know how to navigate, how to tackle the concept and answer the questions. Let's not waste more of your precious time. Let's start with question number 1. Question 1. A 25 years old woman takes a large dose of unknown herbal supplement. Some people do this. I don't know how they do this. They go online to order herbal and take it. Anyway, this woman is agitated, has dry skin, dilated pupil, and her heart rate is 122. So her heart is pumping like crazy. Which of the following drug could most appropriately reverse these symptoms? So before we read option, before we think about it, we need to understand what's happening here. So this lady, to take a medication, she does not know what's happening with this medication, but she's ending up by clinical picture. So which of those will reverse this? Ephedrine, Physostigmine, atropine, naloxone, flumazenil. So let's understand what's happening here. So what's happening here is what we call anticholinergic toxicity. The patient have this clinical picture, agitation, mydriasis, dry skin, tachycardia. This is a hallmark sign for this one. This is likely due to antimuscarinic substance, so atropine containing herbs like datura. So you remember like when we were kids, we watched this like movies and related to one when he go to like Africa, he go to jungle and someone is hitting him with this boom, so he lost his consciousness and most likely he will be dead because of those material ending up by this clinical picture. So physostigmine here is reversible acetylcholine esterase inhibitor that cross the blood-brain barrier, increase acetylcholine at both central and peripheral muscarinic synapse, and this will reverse both CNS and peripheral anticholinergic effect happening for this poor lady. So this is what's happening. This is the medication she did take and this is what's happening for her. So when you give this physostigmine, it's going to reverse everything happened for this patient and hopefully this will save her life. Understanding of parasympathetic system, sympathetic system is of extreme importance for the AFK exam because this will make your life easy when you move forward for cardiovascular system medication, CNS medication. It will make your life easy and make you understand what's happening. So as you can see, cholinergic drugs which mimicking, acting like physostigmine, donazepam, will mimic the function of acetylcholine, contract pinpoint pupil, decrease heart rate, no change in temperature, active bowel sound, sweating, increase secretion and urination. On the other hand, atropine, which is blocking the action, it will lead to mydriasis, dilute, increase in blood pressure. Why this happening? This is indirect because we have our heart now has sympathetic, parasympathetic. I did block the parasympathetic. So sympathetic is working unopposed. So it will lead to increase in everything. To make it easier for yourself, think about cholinergic to be rest and digest and sympathetic to be fight and flight. So physostigmine is inhibitor, which is crossing the acetylcholine esterase inhibitor, which cross blood-brain barrier. Ephedrine, this is sympatomimetic. Mimetic mean like act like. So this is resemble what is happening in sympathetic system. This will kill your patient. Atropine, muscarinic antagonist, cause the same toxicity profile. Again, it will aggravate the problem. Naloxone, this is opioid antagonist, and flumazenil, this is Benz antagonist. So if patient is hyper sedation or the patient having this respiratory depression due to PENS, we can use this one. This is comparative antagonist. Or patient at respiratory depression using cocaine, like using this opioids, we can give naloxone to reverse the action of this one. And for each question, I will just give you one follow-up question just to tickle your knowledge, and I hope you can write the answer in the comment. Okay, what is the clinical picture where you need to give your patient epinephrine? What is the condition you think about it to be dealt with epinephrine? And what is the triggering point for this one? Let's go to question number 2. A hypertensive patient is prescribed a drug that is lower blood pressure by reducing sympathetic outflow from the brainstem. So this medication is working here, not working here. After a week, he presents with fatigue and rebound hypertension after missing a few doses. So a patient, and this is very common, patient, you give him medication, he's fine. After a few weeks, he's getting rid of this medication. So he end up by rebound hypertension. Which of those? Prazosin, methyl-dopa, clonidine, lisinopril, or propranolol? So before we answer this question, we need to understand the selectivity of the receptor. We have alpha 1, alpha 2, beta 1, beta 2. In my understanding, your understanding, everyone common understanding, we think like alpha 2, beta 1, beta 2, if it's mimicking, if it's like agonized, like giving medication to mimic its action, it will increase the blood pressure, which is correct, unless it's working selectively over this one. Why? Because this is, as you think, this is the brake. This is the system, sympathetic, firing as a one unit. So if it's firing as a one unit, unopposed by anything else, it will make you boom. So it should have this like limiting factor inside it. So alpha 2 agonist will lead to decrease in insulin release, decrease in norepinephrine release. So think about medication decreasing the norepinephrine release. What is going to do for the blood pressure? Correct, is going to reduce the blood pressure. And this is the weird action of this medication, clonidine, because this is centrally acting alpha 2 adrenergic agonist. So when you hear adrenergic agonist, all you think about is increase chronotropic, inotropic, increase in blood pressure, but this is the other way around it. And they love this medication so much, so it's coming the outlier concept, so you need to be vigilant about this one. This will stimulate presynaptic alpha 2 receptor in the brainstem, leads to decreased sympathetic tone, decrease in peripheral vascular resistance, and decrease in blood pressure. However, sudden withdrawal can result in rebound hypertension because unopposed sympathetic activity, headache, sweating, tachycardia, often described as hypertensive crisis in non-compliant patient. Let's see our other option, because every question I would love you to go through the other option, why we didn't pick it, and what is the action of this one, because understanding the action of each drug will save you a lot of questions in the exam. Prazosin, this is peripheral alpha 1 blocker, can cause orthostatic hypertension, but this patient will not end up by rebound effect. Methyl-dopa, this is central alpha 2 agonist, correct, but this is a weak one. Used more in pregnancy, less rebound risk than clonidine. Lisinopril, this is ACE inhibitor, no effect over the CNS outflow, so it will not end up by rebound sympathetic activity. Propranolol, this is beta blocker, non-selective because olol, so beta blocker. If it's allol, like carvedilol, this is mixed alpha beta, and in the beta blocker ending up by olol, starting from A to M, it will be selective beta blocker. This is also a good mnemonic for you to memorize the medication and make it easy for you to remember it later. Can cause rebound tachycardia, but less sudden hypertension. Okay, and a follow-up question for you. Patient with hypertension, what is your first line of treatment? What is your first line of treatment for this patient? You would manipulate the receptor, or you should give him diuretics to get rid of the excessive fluid in his body? Let me know in the comment section. Okay, next question. A 48-year-old man with Parkinson's disease develops psychotic symptoms. Which of the following drug would be most appropriate for treating his psychosis without worsening motor symptoms? So this patient has Parkinson's, and sadly he ends up with the psychotic symptoms. So we need to treat it, but at the same time do not worsen his motor action, his motor, which is already compromised by having this Parkinson's disease. Haloperidol, risperidone, clozapine, flufenazine, or metoclopramide. Let's see, this is a very tricky one. Okay, so what is the meaning of Parkinson? Parkinson involves dopaminergic neuron loss and the substania nigra. So inside your brain, we have this neuron which is giving dopamine, which is giving acetylcholine related to learning, relating to memory. This neuron, sadly, it lost its function. So sometime it will have problem even related to antipsychosis. Many antipsychotic worsen PD symptoms, Parkinson's disease symptoms, by blocking dopamine receptors, especially in the noradrenergic pathway. So this patient has a problem and we're giving him some medication to deal with this problem, which is Parkinson, ending up by extra problem. And this is why the CNS medication is a really tricky one and it requires a lot of investment from your side to be sure about it. In this case, Clozapine, which is atypical antipsychotic, is the preferred agent for psychosis in Parkinson's disease. Why? It has minimal D2 receptor blockage in the motor pathway, primary block 5-HT2A receptor, which is very low extrapyramidal side effect. So the problem with typical antipsychosis, we have a slide for this one specifically, it ends up by extrapyramidal symptoms. Extrapyramidal symptoms, it mimicking the Parkinson's disease. So it's not Parkinson's disease, but it mimics this clinical picture of Parkinson's. So patient has Parkinson's disease and ending up by this, it will be not wise to give him typical antipsychosis to get rid of psychosis and worsen his Parkinson condition. So this is why we go with the second family, which is atypical anti-medication. So look here at this one. So in the first generation, we have haloperidol, chlorpheniramine, which is very common to be used. And as you can see, a mnemonic maybe can help you to memorize this one. But this one, the first generation, block dopamine receptor. Second, block dopamine receptor and serotonin receptor. So the second will have less side effect. And the first, we have extrapyramidal sign more. And the second generation, we have less, which is come hand in hand with this case where the patient, to start with, he has Parkinson's disease. As you can see in the second generation, we have clozapine, risperidone, and you can see done and pine to be related to this one. This mnemonic is 100% not 100% accurate for all medication, but it's a good way to start. At least when you are quartered, at least I know something, I have something to go back in my mind. And this is like a screenshot from our notes. So this is how we study. As you can see, I try my best to add something from textbook, add some colors to make it easy, because like I know studying from black and white notes is really annoying. It used to drive me crazy. I hate it like hell. Okay, let's see. Haloperidol, this is typical antipsychotic. So given to the patient, yes, it will deal with his psychosis, but worsen his Parkinson condition. Risperidone, this is atypical, stronger D2 blockage, still cause extrapyramidal at a higher dose. Flofenazine, which is typical antipsychosis, potent, but again worsen the motor function, which we call it extrapyramidal symptoms. Metoclopramide, this is D2 antagonist. This can induce drug-induced Parkinson. So it's not worsen, it will lead to more extrapyramidal effect, and even we call it drug-induced Parkinson for this patient. Okay, so the answer here is Clozapine. Next question. A 55-year-old hypertensive patient present with generalized gingival overgrowth during a routine dental checkup. He has no history of seizure or transplant. Which of the following drug is most likely cause of this finding? Phenytoin, carbamazepine, nifedipine, metoprolol, digoxin. So this topic, gingival overgrowth or gingival hyperplasia, this is you. You are the dentist. You are the expert here. You should understand this concept in, out, everything, the medication, the mode of action of this medication ending up by this, how you diagnose it, how you treat it. And this is just to ask you, I hope you have the answer. This is plaque-induced or non-plaque-induced gingival hyperplasia due to medication. This is plaque-induced or non-plaque-induced, and how you manage it. I hope you can write in the comment section how you think about it. Okay, going back to question. Phenytoin, nifedipine, carbamazepine. So we have a lot of medication ending up by this common gingival hypergrowth. How we can know this? And this is very common. Please, when you have this confusion, you need to read the question again. So I have more than one medication here ending up by this. I need to read the question again. Maybe he giving me a keyword. So the keyword here, patient, the question telling you no history of seizure or transplant. Let's see why this is very important keyword. So gingival hyperplasia, gum overgrowth, is a well-documented side effect associated with certain drugs. Phenytoin, which is anticonvulsant, cyclosporin, which is immunosuppression medication, nifedipine, which is dihydropamide calcium channel blocker, CCB. Nifedipine here is the one related to this one. Why? Because simply the question telling you no history of seizure, so no phenytoin, and no transplant, so nothing related to the cyclosporin medication. So nifedipine, how does it lead to this one? And please, this is important, you need to know. Phenytoin, why end up by this? Nifedipine, why end up by this? This is important, please understand this one. Nifedipine increase extracellular matrix production in gingival tissue and reduce collagen degradation, leading to overgrowth. Seen more in patients with poor oral hygiene, so I hope this answers the question about is plaque induced or non-plaque induced, more common with long-term use. States no seizure history, the question, ruling out phenytoin, typically used for epilepsy, also rule out cyclosporin indirectly by excluding transplant history. So here, nifedipine, phenytoin, yes, but we are going to exclude phenytoin, and we are also going to exclude carbamazepine. Carbamazepine can lead to this one, but it's not very common. It's not very common. Digoxin, metoprolol, for sure, is not related to this side effect. So my follow-up question here, patient come to you having this problem. What is the initial management and what is the definitive management? Last question for today. A hospitalized patient with MRSA bacteremia is prescribed an antibiotic that inhibits bacterial cell wall synthesis by binding directly to the DALA, D-A-L-A, terminus of the peptidoglycan precursors, preventing polymerization. Which of the following drug was most likely prescribed? So he's telling me I gave him the medication working by this. So which of those? Cefotraxime, vancomycin, meropenem, azithromycin, or linezolid. So understanding of MOA, which is mode of action of each medication, is of utmost importance for AFK because it can give you some few questions. And they will not ask you about the penicillin, amoxicillin. It will come to like slightly not very common medication like the vancomycin. So vancomycin is usually used to treat MRSA. You can think about this is a big gun. Again, this is a slide from our notes. This is the big gun used to treat the infection. So we don't use it initially. What is the most commonly used medication in dentistry is amazing, amox and penicillin. This is what we love to use. Okay, and we move to clindamycin, but not anymore. We move to azithromycin because clinda is related to, related to GIT upset. So this medication has tons of side effects. Discoloration of body fluid, brownish discoloration, ototoxicity, hearing loss or balance problem, and sometimes end up at what we call red man syndrome. So thrombocytopenia, thrombophlebitis, ototoxicity, nephrotoxicity, and red man syndrome. So related to flushing of the skin, particularly the upper body and face, resembling what we call red man. So this is the vancomycin side effect. And this vancomycin is glycopeptide antibiotic that inhibits cell wall synthesis by directly binding to the LAL terminus of the nascent peptidoglycan chain. This blockage step in gram-positive bacteria. This is in contrast to beta-lactamase, which is the other medication which inhibit penicillin binding protein. So this coming from the same family, but it's different way of acting. So it's yes, working over the cell wall, correct, but it's working over a different level of the cell wall. Vancomycin is the drug of choice for MRSA and other gram-positive infectious resistance to beta-lactamase. So we start with beta-lactamase. If it's not working, we are going to go to vancomycin. So this is the other medication. This is third generation cephalosporin. This is beta-lactamase class, azithromycin, monobactam, linezolid, which is protein sensitive inhibitor. So they're totally different family related to 50S ribosome, not a cell wall. So for MRSA, this is what we are going to give for our patient. My follow-up question and last question for today. This patient who has MRSA, he has complete denture, and we suspect this complete denture to have some infection from MRSA. What is the, you can say, substance or the material you are going to use to disinfect his complete denture? If you have any clue about this one, write me in the comment, and thank you for following till the end. I hope those 5 questions give you some insight about how you should study, how you should go with the mechanism of action, side effect. This is my humble way of doing this, and I hope you can study this way, because this is how you can be sure about your level of knowledge and can answer the question with confidence. And trust me, this is very, very important. Thank you, and see you next Sunday.